Try It Out Loud, a podcast by Chasing the Rainbows with your host, Bernice Quisenberry.
Today, we're diving into a topic that is often overlooked in fertility conversations, but is responsible for nearly half of infertility cases, and that's male factor infertility. Joining us today is Dr. Russell Hayden, a urologist who specializes in male infertility and microsurgery at the Center for Male Fertility at Shady Grove Fertility. Dr. Hayden's path to reproductive medicine began during his graduate studies in biomedical engineering at Johns Hopkins University, where he became interested in the intersection of technology, precision medicine, and creative problem solving. He went on to earn his medical degree from Harvard University, followed by residencies in general surgery and urology at Massachusetts General Hospital. He then completed a fellowship in reproductive medicine and microsurgery at Weill Cornell Medicine, one of the leading training programs in male fertility. His work focuses on diagnosing and treating complex male infertility conditions, including sperm retrieval procedures, advanced microsurgical procedures that often involve operating under magnification as high as 25 times finer than a human hair. Dr. Hayden is a member of several leading medical societies, including the American Urological, Association, the American Society for Reproductive Medicine, and the Society for Male Reproduction and Urology. And he has published research on a range of topics related to reproductive and health. And Dr. Hayden, thank you so much for being here and shedding light on part of fertility that many families don't fully understand, but plays a crucial role in building a family.
My pleasure. Happy to answer any questions you have.
Fantastic. Yeah, we have a lot from our listeners, from our lost parents. So we'll just dive right in. Many people, still assume infertility is primarily a woman issue. From a medical standpoint, how often is male factor infertility contributing to difficulty conceiving?
Oh, it's much more common than we all originally anticipated. And I always like to say it takes two to tango. Yeah. Each person is contributing 50% of their DNA. There is definitely a factor of sperm quality that goes into embryo development. I'm a firm believer in that. And I think it's reasonable to say that male factor is going to be 50% of cases.
Yeah, absolutely. Well, even, between the two, right? Between the partners as well, 1/3 it's female, 1/3 it's male, but then when they come together, how that does play a role as well.
Yeah, we're seeing a lot of dual factors, so to speak.
Yes.
A little bit of inefficiency on the male side in terms of sperm counts can really compound any issues on the female side and make it really challenging to get pregnant.
Absolutely. Yeah. And, understanding too. So this is a big part of it, is understanding semen analysis. But what, don't fully understand is what those numbers actually mean when we get them back and things like that. So can you walk us through sperm count, morphology, DNA fragmentation, and what they actually tell us about the fertility potential?
Absolutely. So the first thing I tell my patients is expectations. The semen analysis is a crude test. It remains the cornerstone of how we assess a male's fertility potential, but it doesn't do a great job telling us things like sperm quality, whether or not the sperm work or not. It's essentially best used as a lottery ticket counter, which matters because humans are inefficient reproducers by their nature. You need a lot of lottery tickets to have an efficient chance to routinely hit the egg during that ovulation window. Wow. So I primarily use the semen analysis as a lottery ticket counter. Your total motile sperm count is the most important number on that entire report sheet.
Wow.
That being said, when there's isolated deficits, say you have a normal count but no motility, that's a big deal. And that could be other issues related to plumbing or how the factory makes sperm. And that requires a little bit more of a subtle eye.
Yeah.
Sperm morphology is not a good test. And I don't want anybody being super anxious over sperm morphology.
Yeah.
They only count 200 cells typically from the millions that are there to create that number. It is inter-user dependent, meaning if you sit a different andrologist down at that microscope, it may be a different number that they generate.
Wow.
Additionally, you Google this stuff, the most inflammatory old studies that weren't done well are going to come up right off the bat. And this is where a lot of anxiety is created in my couples. I don't like it. The newer data that's done properly with large cohorts of patients demonstrates that morphology, even when it's 0%, essentially has very little impact on time to conception compared to normal, IUI pregnancy rates, birth defects are the same. That doesn't increase. And even with IVF ICSI, if that's what you have to do, it appears that the outcomes are about similar, comparing 0% morphology to normal. So for most individuals, I tell them to completely ignore morphology altogether. It sounds scary. It just didn't turn out to be as useful as we all thought it would be 40 years ago.
Yeah.
Now, DNA fragmentation is a tougher topic. There is a lot of mixed data out there, and your head will spin if you Google this. A lot of conflicting reports. There have been some findings that have been readily reproduced that I think we can hang our hat on at this point. You can have a normal semen analysis, but be completely out of whack on your DNA fragmentation. So we've seen that. It's rare, but occasionally we'll find that's the problem. DNA fragmentation sounds important, like it's all about the DNA. But in reality, it's just a measure of sperm damage. We measure the DNA because the assay is easier to do it on that. But if there's holes blown through the DNA, there's holes blown through the tail, through the membrane, through the motor. That global damage of the sperm cell is really what we're assessing with DNA fragmentation. The findings that have been reproduced are that if you're excessively high on DNA fragmentation, it is much harder to achieve a successful pregnancy by natural conception. And in line with that, intrauterine insemination is tough as well. I always call IUI natural conception with a sperm Uber. It's the same physiology. A lot of men with elevated DNA fragmentation may ultimately require IVF. And for most of those guys, they are going to have almost equivalent outcomes to their normal counterparts.
Okay.
But occasionally we will have to do something fancy, such as retrieving sperm directly out of the testicle from the factory where we know the DNA frag is less if we're not doing well at IVF. Interestingly, we now know that every sperm in every man has damage. It is up to the egg to repair that DNA damage before the embryo develops. So if you do invest in a DNA fragmentation test, it's not going to be zero. Okay, it's going to be somewhere in the low range, hopefully.
Yeah, that's so interesting. And so with sperm DNA fragmentation, how might it contribute to also recurrent pregnancy loss?
Yeah, so I look at recurrent pregnancy loss as recurrent miscarriage, right? Yeah. Exactly. That's how you would say it.
Yeah.
So, but I also look at couples who have essentially normal testing who are not getting pregnant. I wonder if they're making embryos, but they're passing and looking like a period, right? So I also think there's an overlap there of recurrent pregnancy loss or recurrent miscarriage.
Yeah.
We have found, this is another finding that you can hang your hat on, increased DNA fragmentation. It's got to be pretty high, can definitely increase your risk of miscarriage. So I routinely send these in my RPL, recurrent pregnancy loss patients.
Yeah. Wow. Thanks, Russ, for that.
Yeah.
Yeah, because, one of the frustrating things, well, one, like you were saying, Google deep dives, right? When we're in an infertility journey, we do that. So we're going to research everything from male factor, female factor, all the things. And when this stuff is coming up, it's really scary because like you're saying, it's old studies that are being found, the things that were clicked on the most over the last 40 years,
Right.
all of that is really what's going to show. And, having things available to us, yeah, it's good, if you educate to advocate for yourself, but if you do it with the right things and the right knowledge and having it, that's power, versus finding those old things that make you almost more high anxiety going into these situations with your doc and going in like, this is what we need to do. And realistically, these tests aren't always needed.
No, they're not. In fact, the guidelines say that DNA fragmentation should be considered optional. We don't know where to put it yet. Yeah. But I definitely think it plays a good role in the evaluation for your recurrent miscarriage.
Yeah.
For your unexplained, sometimes that's the right test to obtain. But yeah, you got to be careful with Google. It's driven by clicks. Yeah. And if an older study only has 10 patients in it, that's not good data.
No, absolutely not. No. And thanks for pointing that out. Something that's really frustrating for couples, and we talk about this too, is they go home to Google, but also those like normal results, which still lead to infertility. And when couples are really struggling to conceive, what hidden or advanced male factors might not show up on just basic testing?
There's a tremendous amount. And honestly, medicine has been slow on the male side in terms of developing better tests.
Yeah.
DNA fragmentation has been around for a few decades. It's probably the most used fancy sperm test, I would say.
Yeah.
But the semen analysis, like I said before, is crude. It's somebody looking through a microscope with their naked eyeball.
Yeah.
They can't tell you much beyond the visual appearance of those cells and whether or not they're moving. The sperm has a lot to do. It has to hone to an egg. So you need progressive motility. It needs to fuse with the egg, fertilization. And that process also is dependent upon the egg itself. There's newer reports that the egg has to allow the sperm in, so to speak.
Yeah.
After that, sperm DNA is actually packaged completely uniquely compared to every other cell in your entire body. It is packaged tight. This is one of the smallest cells we make. That has to be unpackaged for the embryo to develop. And we do see correlations in terms of how DNA is packaged with male factor fertility. I wouldn't invest in any commercial tests right now for that specific type of testing. But there are newer tests coming online trying to assess the functional aspect of sperm, not just how they appear. That's exciting, but we are in very early days. And I caution my patients about purchasing these fancier sperm tests. They're hard to interpret without the depth of history declaring their normal values.
Yeah, absolutely. Yeah. And, one of the devastating, along with a lot, when a couple is going through infertility, is getting that diagnosis when there's no sperm found in the ejaculate. What are some main causes of that, and what options exist today that many patients might not realize are possible?
Yeah, it's not over. Not yet.
Good.
Okay.
Good. Yeah.
This is what I specifically trained for. There are two causes. Let's keep it simple. Either the factory's online, but the highways are down, blockage. Okay. Or the highways are wide open, but the factory is down, production. Okay. So we either have a production problem or a highway problem, obstruction. You can usually determine which one of the two it's going to be through a physical exam and a basic hormone evaluation. We are pretty good at predicting that. Both require slightly different surgeries. If it's blockage, you're in much better shape. Those are typically fantastic sperm. Doesn't take much to get them out. A blind man can hit the side of a barn, okay, with a rock. You're chock full of it. We just got to get them out, okay?
Yeah.
Unfortunately, you have to understand that surgically retrieved sperm across the board only works with IVF. It will not work with an intrauterine insemination type deal, okay? We learned that in the early 90s. And until ICSI came on board in 1997, surgical sperm never worked. Okay. Now, if it's a production problem, the factory is down, then we'd have a lot more work to do. I need to rule out some chromosome abnormalities that are common. We can still find rare sperm in some of those men, but the prognosis is much more guarded. It's tough. It's a tough journey.
Yeah.
The name of the surgery for that is called a microsurgery. And essentially what we're doing is combing through, attempting to find ultra rare pockets of sperm production. What we don't understand is why they exist in the first place.
Yeah.
Presumably the genetics are the same throughout the entire testicle. But for some reason, most of the factory is off with the lights down. And every once in a while, you'll come across a pocket where the factory is going hog wild and completing fully mature sperm. Realistically, I would have to see a patient before I gave them a % chance of finding sperm, but it's about 55% for most men, based upon prior literature. So it's tough. I spend a lot of time with those couples discussing donor backup as an option, and talking to a reproductive urologist in terms of donor sperm, I think is useful. You know, this is hard for men. It's hard for couples to accept, but sperm don't make the dad at the end of the day.
Oh, that's such a good way of putting it, Russ. Absolutely. I know going into the donor discussion, I can't imagine how tough that is to, enter with the couples as the physician.
Yeah, it's important to respect their autonomy.
Yeah.
You give them the data, and I tell them you have homework to do. Take the weekend and call me back and tell me what you want, but I'm not going to force you to use donor sperm.
Yeah. Yeah, absolutely. Yeah. I mean, the whole aspect of everything along this, and getting those, how it's delivered, having a physician like yourself who's compassionate, caring, and giving everything up front. Like, this is what we're seeing. It's so important because, infertility in and of itself is complex trauma, because it's like loss after loss, and just you feel like your bottoms just keep getting lower and lower in this journey, and like, oh, we're going to try this next, we're going to do this next, those things. So having someone that is clearly transparent with you in those moments is so vital and crucial. So you can feel like I can make the best educated decision as a couple, what we can do for our family planning and what that looks like and what we're comfortable doing and what we're not, based off of that and the studies.
Yeah, I think it's important as a physician to don't hold anything back. As transparent and sometimes as brutal as possible is what you need. You need the data to make your decisions.
Yes.
And the data is either good or bad, but you need it. And so I think that physician-patient relationship is especially important in fertility.
Yeah. And finding the one that you relate the best with and has that open communication, like you're saying, Russ, because they're alongside you the whole time with your family planning. And
it takes a long time. Yeah. Going into fertility treatments, it always takes longer than you expect.
Yeah, absolutely. Well, and having these conversations is so vital up front, and earlier the better, understanding that as well. And the next question I was going to ask was about the testing. So I'm really glad that you went into that. So thank you for that, Russ. And, on top of understanding the factory or the highways, those things, with production or distribution of the sperm, what other, lifestyle and environmental factors really play a role in sperm health that, might be easier to change or, help with this, like toxins exposure, heat exposure, alcohol, cannabis, sleep, stress, and nutrition? They're always the big top ones I feel like we hear about all the time.
Yeah. So I always say the lifestyle of male reproduction is the lifestyle of moderation. As long as you're not too extreme on any end of the spectrum, you want to be in the middle. That's where your body is happy. So, for instance, going on a crash diet is a bad idea. So if you need to lose weight, you should do it low and slow. A crash diet is a controlled famine. Humans do not reproduce during famine. That's on purpose. Alcohol probably matters, but I typically need to see pretty heavy drinking before it starts really impacting the semen analyses. In general, though, I'd like to keep my patients below 4 to 5 drinks spaced out in a week.
Yeah.
Smoking is the worst you can do. This is probably the most impactful lifestyle factor that you can change to improve your sperm. Nicotine affects sperm, but it's really all the other stuff that's coming out of the combustion of that plant that is highly damaging to sperm. And we know that it increases DNA fragmentation. We've measured, okay? Cannabis is the same thing. I don't care about the THC as much as the other stuff coming out of the burning plant. It's like 3 unfiltered cigarettes. Now, there are THC receptors down there. We don't know what they do. It's probably a minor effect in terms of the active chemical, but I still tell my patients, remove variables, cut that stuff out, okay? In terms of diet, it's tough to move the needle. You know, you'll read these studies, but the effect size is very small. The truth is, in Western society, we are all macro and micronutrient sufficient. And I have guys who disappear on me for 6 months and they go live the perfect lifestyle. They hit the gym every day, perfect Mediterranean diet, taking their supplements. They come back, they repeat their semen analysis. It's exactly the same. And so it's it's tough to move the needle when you're already doing okay. Yeah. There are prescription meds that can influence sperm production. If you Google any prescription med, I guarantee you will find some sort of random animal study or vague human study that links it to sperm. I don't want you to get too into it until you talk to somebody like myself, but there are a few bad players. And I don't know if this is one of your future questions, but testosterone replacement therapy is a nightmare. That is essentially going to be a male contraceptive for most men. It turns sperm production off, and it can take a long time to get you back online. Some men, it took me a year. So that has become, unfortunately, very, very common. It's being pushed on our population, and you're not always counseled before you start testosterone replacement therapy that it affects your sperm count. And so a lot of folks are getting kind of bamboozled into a difficult fertility situation.
Absolutely. And a year in infertility is a long time when you're trying to conceive.
Yeah. Anabolic steroids are the same thing. If you're abusing those, it's like testosterone on steroids, no pun intended.
Yeah. Wow.
That was a big question. Did I miss any of those segments?
Oh, how about, this is always a big one. You know, everybody says like, just relax, you know, if you didn't have stress, but it's hard not to stress when you're in an infertility journey. But how does stress and sleep really associate with it too?
Yeah. Again, loose correlations.
Yeah.
Okay.
Yeah.
Every patient is hoping it's the stress. It's not the stress.
Yeah.
You have very little control over your sperm counts. And we all live stressful lifestyles these days.
Yes. Yes.
I do think a severe event can temporarily affect your sperm counts, such death of a close loved one, for instance.
Yeah.
Now, sleep is interesting. I think sleep's very important. None of us have good sleep hygiene, it seems. Yeah. But remember, the testosterone axis is it cycles day to day. If your days are different every single day of the week, your body's having a hard time regulating that testosterone cycle that kind of follows your sleep-wake cycle. So if not for general health, I think it's nice to remove that variable. I preach a lot of sleep hygiene for my patients. I think it's very important.
Yeah, that's good to know, Russ. I mean, you don't hear about it as often as you hear about the others that we discussed. I feel like, you know, the alcohol, the cannabis, the nicotine, they always get all the, you know, attention out there. But, you know, sleep, that routine and having a really healthy sleep pattern. Yeah.
Exactly. You got to sleep.
No. And that's something you can fix, you know, like that's something you can do on your own, you know, figure it out and what works for you. Yeah. Right. Yeah. Taking that variable out. You know, what's interesting is too, something that, especially from the female perspective, is our biological clock, right? And we're like, eggs are on a timer, for lack of a better way of saying it. But male age is discussed less frequently. How does male age impact, sperm quality, genetics, and pregnancy outcomes?
Not very much, as
Yeah.
as you would expect,
Yeah.
but it does matter.
Yeah.
But the correlations are pretty soft. It's not like a huge change occurs after 5-10 years.
Yeah.
But there is a progressive drop with age, with testosterone and sperm counts. As you get older and older, there is concern that some of these polygenetic diseases like autism, for instance, may slightly increase with male age in terms of risk.
Mhm.
I think it's reasonable to assume that makes sense,
Yeah.
but I wouldn't say that should significantly influence your decisions because the absolute risk remains pretty low comparable to everyone else. But this is why you see much older men able to start pregnancies.
Yeah, absolutely. That makes sense. For some men, infertility also has a genetic cause. What does types of genetic conditions or chromosome abnormalities affecting the sperm production when you see that, Ross?
Yeah. So again, the science is limited.
Yeah.
But what I can tell you, there's something in the genetics that's affecting you if you're having significant diminished sperm counts or motility. Okay. We have spent millions upon millions in research through the NIH, et cetera, trying to identify these genes. It is an extremely complex system, and we've just scratched the surface. It takes hundreds of genes to make a sperm. As unique individuals, we have a unique variant in each one of those genes. These genes come from far out stretches of your family tree. You get some of them from great-great-grandma on one side, great-granddad on the other side. It's the unique mixture of these gene variants, your hand of cards, that matters and is going to affect what I call your factory efficiency. How much product can you make, right?
Yeah.
That being said, there are a few, if you Google this, there are some genes that have been identified, but they're typically only applicable to very small groups of people, very specific families that have a very specific problem. Yeah. The only real good genetic testing we have, and that is pretty old and dated at this point, but we still use it, is the chromosome analysis, aka karyotype, and the Y chromosome microdeletion test. If you have azoospermia, no sperm in the ejaculate, or you're shooting very low sperm counts, I will order these tests. We need to rule them out. Yeah. It will detect chromosome rearrangements, Klinefelter syndrome, and loss of that specific spot on that Y chromosome. Think of your chromosomes like the Encyclopedia Britannica. They're divided into volumes. As long as you have all the text, you can be a totally normal human. But if part of 5 is stuck to 6, it makes it very difficult to produce sperm because you got to split these chromosomes into separate cells. So you can have that. Klinefelter syndrome is a syndrome where you have an extra X chromosome. So you have XXY. I believe it's far more common than we all initially anticipated. For most men, you can't tell the difference until your infertility diagnosis. Those men typically require a microtesty if they have a shot to find sperm. It needs to be ruled out if you're having 0 sperm in the ejaculate. The Y chromosome microdeletion is interesting. This is not typically passed down because you typically don't have any sperm or very low amounts of sperm. So in the past, you would have been totally infertile. Yeah. It is a hot spot on the Y chromosome that tends to fall out easily. And it happens right at conception when egg and sperm meet. And this is why it's not carried down in families yet. However, if I find sperm in a guy with a Y chromosome microdeletion and we make an embryo that's a boy, now it will be passed down because he's going to get your Y chromosome. So it's still a relevant measure because in some cases, those couples may gender select.
Yeah, absolutely. No, a lot to consider and think about that you have to in these instances.
Absolutely.
Wow. And, with that, and with a couple who is on an infertility journey or feel like they've been trying to conceive for months, maybe even years, when do you feel like, because obviously many couples focus first testing on the female, even though it is easier to test in the male, right? When should men be referred to a male fertility specialist rather than just a basic semen test?
Yeah. So first of all, a semen test, and typically 2. It's important to get more than 1 for most guys because it is a very extremely variable system. You can have bad days. You got to retest to make sure it's true or not. You should have your semen analyses done right away, immediately.
Right. Yeah.
Right. Along with, as you start your journey, that has to be factored in. I would say referral to a male infertility specialist is reasonable if there's a consistent defect, either in count or motility. Okay. Obviously, if there's ejaculatory dysfunction, that's an early referral too, right? We got to have ejaculate to get pregnant.
Yeah, absolutely.
And other sexual dysfunction we can address as well. But ejaculatory reflex is the big one that needs to be intact.
Yeah.
That being said, I don't mind seeing folks with normal semen analyses. I think there's a lot of value in talking about lifestyle, discussing the testing thus far, and reviewing the data together in a shared capacity. I think that's helpful. We can also discuss the fancier sperm tests if we want to go down that route, which I believe can be a predatory market. You got to be careful how you spend your money. So I can help guide you in terms of, I don't think that test is really ready for prime time yet. Let's not utilize that one versus this one, which I think is probably much more effective in guiding my patients. So I think that's a reasonable thing to consider as well.
And for couples listening who may have just received a diagnosis involving male infertility or are just starting this journey, what would you want them to understand about how far treatments and technology have come?
Yeah. So I always tell my couples the testing is limited.
Yeah.
Only interpret your tests with what the test can actually tell you. So if you have a normal test, but your morphology is 0, you don't know much about that male other than he has a normal motile sperm count, most likely. I wouldn't weigh into the morphology too much, as I said earlier in the talk.
Yeah.
I think, like I said, the semen analysis, typically 2. I have a low threshold to get 3. You have to understand that the male stock market really varies day to day. And so you can get some wonky tests on your semen analyses. Always repeat. But overall, I think it's high value still to see someone like me to review these things and have a discussion. It's not much time, and really, I always tell my folks 90% of what I do is education, 10% weird stuff.
Yeah. It's good to know.
Yeah.
So Russ, what would you like to leave our listeners with? And also, if you could change one misconception the public has about male fertility, what would it be?
Yeah. Number 1. The testicles only contribute 3% of the volume to the ejaculate. If the guy is saying, I have a normal looking ejaculate, it doesn't matter. You don't know if sperm is in there or not. He needs a semen analysis. Okay. That's why after vasectomy, for instance, the ejaculate looks unchanged. Okay.
Yeah.
Abstinence interval is not as important as we all think it is. We focus on it because it's one of the few things you can control. But by and large, it's not that important. what I would like to leave my folks with is that you got to rule out a male factor, and you should do it early. It takes 2 to tango. Just get the semen analysis. It's not a big deal.
I know. I think that's tough, especially with males, maybe to venture into, realizing there might be something contributing or wrong that can be fixed or, not, but just to have those conversations. And a lot of times, our lost parents and couples and the moms come to us, and they're thinking it's a lot of things they're getting done on their side and the males are more dragging their feet with things. So to hear that, Russ, is huge.
You just got to do it. Do your business.
Yeah. Get it done.
Get it done.
Great. Thank you so much, Dr. Hayden, for being here, for everything that you covered, you shared about male infertility. Definitely encourage anybody listening that has follow-up questions or would like to do a consult with Dr. Russell, please reach out to him. We'll put the contact information in the description so you have all of that. And thanks again, Russ. Can't say that enough to you.
Absolutely. My pleasure.
To everyone that is listening, that is navigating infertility, recurrent pregnancy loss, any type of pregnancy loss, infant loss, please know your story matters, your baby matters, and your grief matter. Healing doesn't always follow a timeline. Trauma and loss don't have a schedule, and you deserve compassionate care through every step of your journey. If you need support, we have free daily support resources and a community at Chasing the Rainbows, because every loss does matter. If this conversation resonated with you, please share this episode with someone who may need it and to hear it as well. And if you are looking for support, want to volunteer, donate, host an event, please visit chasingtherainbows.org. Thank you for being here, for listening, and for continuing to break the silence around infertility and baby loss. Until next time, this is Cry It Out Loud.